next part of discussion is MCA artery Doppler. So in MCA artery Doppler, yes. So MCA artery is middle cerebral artery Doppler. So MCA, that is middle cerebral artery. In circular foliage, so there will be anterocerebral artery, here will be anterocerebral artery, there are two anterocerebral artery, there are two middle cerebral artery and posterior artery. So this will be the circular foliage. So if you put the probe on the middle cerebral artery, we'll get a Doppler like this. The concept behind the middle cerebral artery in uteroplacental insufficiency or fetal hypoxia, that normally during pregnancy in there will be low diastolic flow to the middle cerebral artery. Normally the brain gets its usual blood flow. In case of uteroplacental insufficiency or fetal hypoxia, so if there is fetal hypoxia or uteroplacental insufficiency, the fetus will try to redistribute its blood, maximum amount of blood to the vital organs. So what are the vital organs in fetus? So brain, liver, lung, kidney and heart. So maximum of blood will go to the brain. So that is called as also, this concept is also called as brain sparing effect. That means increased blood flow to the brain during fetal hypoxia or uteroplacental insufficiency, increased blood flow to brain. So how this can be detected? This can be detected in MCA Doppler. So see, in this picture there is low diastolic flow. This is the diastole. See, this is the amount of diastole. See, the systole is long systole with low diastole, long systole with low diastole. That means there is a low diastolic flow in second trimester and in third trimester in middle cerebral artery. Normally, if the fetus is normal. Suppose the fetus is there is a fetal hypoxia or there is decreased blood flow to the uteroplacental insufficiency from placenta, then this was a normal diastolic flow. So if there is decreased blood flow or fetal hypoxia, then fetus will redistribute its own blood to the brain. So that is called brain sparing effect. There will be increased diastolic flow to the brain. So increased diastolic flow means, see, this is the systole and this is the diastole has been from here to here. The diastole has been increased. See, this is the diastole. So the diastole has been increased. That means, so to increase the blood supply to the brain, there will be increased diastole. So increased diastolic flow in MCA Doppler. Previously in umbilical artery Doppler, normally the diastolic flow as pregnancy increases, the diastolic flow also increases. But here in MCA Doppler, if there is fetal hypoxia, then diastolic flow will increase. So this is a reverse. That means if there is fetal hypoxia, then diastolic flow will increase. So what about, then tell me about the PI and RI in MCA Doppler. So SD ratio. What about SD ratio in case of fetal hypoxia? Normally, in normal condition, SD will be high or low. See, there is low diastolic flow. There is low diastolic flow in MCA Doppler normally. So S by D is low. So SD ratio will be high in normal fetus. In case of hypoxic fetus, SD ratio, so diastole will increase. So diastole will increase in hypoxic fetus. So SD ratio will decrease. And what about pi and ri also? Pi is s minus t by min. So d is increasing. So s minus d will decrease. So pi also will decrease. So in hypoxia, pi will decrease. In ri also, it will also decrease. But in umbilical artery Doppler, if SD normally SD should decrease, pi should decrease, and ri should decrease. In umbilical artery hypoxia, SD increase, pi increase, and ri increase. So this have to remember, and you should have. So do not confuse in MC Doppler pi and umbilical artery Doppler pi. So if we take a combination that is called as cerebroplacental ratio, that is called MC Doppler and umbilical artery Doppler. So cerebroplacental ratio, that is the ratio of MCPI and umbilical artery PI. That means, suppose for example, this is normal fetus. See, umbilical artery Doppler, diastolic flow is good, and in umbilical artery Doppler, diastolic flow is good, normal, high diastolic flow, and in MC Doppler there is low diastolic flow. That means here the CPR will be, for this one, the CPR will be MCA PI by umbilical artery PI. So diastolic flow is less, that means MCA PI will be high. Yes, high or low? So MCA PI normally. So this is normal fetus, na? The diastolic flow is less, so MCA PI will be increased. Again I am telling, for CPR for this one, this is normal fetus, so CPR will be MCA PI by umbilical artery PI. So MCA PI, that means S minus D by M. Also here for umbilical artery also S minus D by M for umbilical artery. See, there is less diastolic flow, so diastolic will decreased. Here high diastolic flow in umbilical artery, so it will be increased. So this PI will high, so MCA PI will be high, and this will be low. So normally this is more than 1. So CPR is more than 1 means it is normally behaving fetus. There is no hypoxia. But here, if you get umbilical artery like this, that means low diastolic flow. And so we will do, when we get a umbilical artery with low diastolic flow, next we will refer the patient to do an MCA PI. So MCA Doppler. So in MCA Doppler, see, there is high diastolic flow. High diastolic flow means there is fetal hypoxia. That means there is redistribution of blood or brain sparing effect. So brain sparing effect. So calculate the CPR here. So CPR will be MCA PI minus divided by umbilical artery PI. So MCA PI is high or low. So diastolic flow is increased. S minus T. Diastolic flow is increased. So this MCA PI will high or low. This will be low. And umbilical artery PI, the diastolic flow is decreased. So PI, umbilical artery PI will be increased, or high, it will be increased. So numerator by denominator, low by high, so it will be less than 1. If CPR is less than 1, so in this case, this is a case of fetal hypoxia, so CPR will be is less than 1. That is, if you put it percentile chart, so it is less than 5th percentile, then it is a sign of termination. But there is a clause. What is the point to remember? In case of preterm SGA, so in case of preterm SGA, it is less than 32 weeks. The RCOG says MCA Doppler has limited accuracy and it should not be used. That is not to be used to time delivery. So MCA Doppler is mainly used for more than 32 weeks, term not for preterm SGA, for more than 32 weeks fetus. So for example, if you get an umbilical artery Doppler, reduced end diastolic flow, so next will patient refer to, we will do a MCA Doppler. And if the MCA Doppler show changes, that is increased diastolic flow, or PI, MCA Doppler PI is more than 95 centile, then accordingly we will plan for delivery depending upon the clinical condition, fetal weight, and risk benefit ratio. So if the umbilical artery Doppler is abnormal, then we'll go for MCA Doppler. And we'll do the if the MCA Doppler PI is more than 95 centile or CPR is less than 5th centile. So how will calculate the centile? So there is a chart. There is a chart for PI, CPR, for everything. There is a chart for 5th centile, 50th median value, and for 19th centile. So we have to put that value in the chart, and we'll see if this value is CPR is less than 5th centile, then we will plan for termination of pregnancy depending upon the clinical conditions and risk benefit ratio, fetal weight, and how much the fetus can survive outside. See, previously, see in this figure chart, I have already told. See this one. For yearly Doppler changes, fetal FGR with mild abnormality, umbilical artery PI is more than 95 centile, MCA PI is less than 5th centile, or CPR is less than 5th centile. That means high PI in umbilical artery or low PI in MCA, and CPR is less than 5th centile, that is less than 1. For these conditions, I have told admit the patient, consider steroid, BPP and ST 1 to 2 times, and Doppler, do Doppler 1 to 2 times per week. Then we can plan delivery at 34 to 37 weeks if everything goes normal. Or if this patient goes into absent or reverse end diastolic flow, then the plan of termination becomes 32 to 34 for absent end diastolic flow, and for reversed it becomes 32 to 32 weeks after steroid cover and fetal monitoring. Then again, if this fetus again reverse end diastolic flow goes, suppose it is less than 30 weeks, so we cannot deliver that. For reverse end diastolic flow, it should be delivered between 30 to 32 weeks. Suppose the fetus is less than 28 weeks, or it is 28 weeks or 29 weeks, then we have to try to bring the fetus to the period of viability, so that as much as period we can bring time for the fetus inside the uterus, so that the baby can survive outside. So then we will do ductus venosus Doppler. So overall risk of stillbirth is 20% in case of abnormal ductus venosus Doppler. This is a question. And so what we'll do? We'll do inpatient monitoring. We'll admit the patient, steroid for long maturation, BPP and NST twice per day, and we'll do daily Doppler. Daily Doppler means ductus venosus flow. We'll check the ductus venosus flow daily, and we'll terminate at 26 to 30 weeks if there is abnormal ductus venosus Doppler. Abnormal means absent or reversal of A wave. Absent or reversal of A wave in ductus venosus in DV Doppler. And mode of delivery is cesarean section. That is between 26 to 30 weeks. We can deliver the fetus based on this parameter. If the fetus was absent or reversed in diastolic flow and she is still very preterm, that is 26 to 30 weeks, then we will check for ductus venosus Doppler. And if this Doppler finding becomes abnormal, then we have to deliver by 26 to 30 weeks. So abnormal ductus venosus Doppler is a sign of imminent fetal hypoxia or cardiac compromise. So what is ductus venosus Doppler? See, ductus venosus, there is a umbilical vein The umbilical vein joins with portal vein in liver, and the maximum amount of blood, that is the oxygenated blood umbilical vein carries, that oxygenated blood bypasses the liver through this ductus venosus to the IVC. So this is the IVC. So ductus venosus is the connection between the umbilical vein and IVC. This is a very small vein that we have to difficult to find in ultrasound. So we have to check the flow in the ductus venosus. I have told earlier the concept behind the ductus venosus pulse or flow, reversal flow. Why? See, again I'm telling, if there is fetal hypoxia, then there will be decrease applied to the myocardium. Once there is decrease applied to the myocardium will be stiffened. It will be contracted or stiffened, so it will not properly pump the blood outside. So there will be accumulation of blood in the myocardium. So blood will get accumulated in the myocardium. Once blood is getting accumulated in the myocardium will be dilated. Dilated means there will be atrioventricular ring. So this ring will be dilated. Once this ring is dilated, that means that is the AV valve or tricuspid valve will not able to pop up. That means the blood will again backflow, because the whole ventricle is filled with blood. Now it cannot receive any blood, so the blood coming from the atrium, right atrium, will not go into the right ventricle, so it will cause backflow into the IVC. So once the blood backflow into the IVC, it is connected to the, so this is the blue color is the, this is the ductus venosus. So once there is backflow in the ductus venosus, initially there will be, so we will get a reversal in the A wave. That means reversal of A wave means the blood is not going to the right ventricle, it is getting backflow from the right atrium. So that means the right ventricle has been failed. So reversal of A wave is a sign that there is cardiac compromise or imminent cardiac failure in the fetus. That's why we are doing this DV Doppler. Previously I have told that initially we do umbilical artery Doppler because there will be decreased cardiac output, ventricle is not contracting properly, so cardiac output is decreasing. So the blood is not going to aorta, not going to common iliac artery and internal iliac artery, and ultimately umbilical artery. So umbilical artery is getting less blood, that means there is decreased output in the initial phases of a fetal hypoxia. So we check the first umbilical artery Doppler. Once umbilical artery Doppler, there is reversal flow, that means there is no blood is coming during the diastolic phase, there is reversal backflow in umbilical artery Doppler. That means now the fetus, the left ventricle is failed. Now the blood is getting accumulated in the right ventricle. So again in right ventricular failed, the right ventricle is getting failed, so it is not contracting, so blood is getting accumulated in the right atrium, again into the IVC. That means it is connected to the ductus venosus. So ductus venosus we are getting a reversal of A wave, that is a indicator of right ventricular failure, that is imminent cardiac failure. So in that conditions, next step is we check umbilical vein pulsation. So ductus venosus is connected to the umbilical vein. Once there is reversal of A wave, we will get pulsation in the umbilical vein. So pulsation in the umbilical vein is the imminent sign that it is a fetal acidemia has already been occurred. So coming to, so this is the concept behind doing Doppler of the ductus venosus. So ductus venosus, there are three waveforms. There is a AS wave. So this is AS wave, this is D wave, and this is A wave. AS wave means ventricular systole. AS wave means ventricular systole. D wave means ventricular diastole. And A wave, this is the A wave. This is the A wave, A wave. A wave means atrial systole. Atrial systole. Initially, in case of fetal hypoxia, so there will be absent A wave. So here the A wave is absent. Absent A wave. This is S D. This is S wave. This is D wave. There is no A wave. So this is S wave, D wave, and no A wave. Now we have not treated that patient. Now not delivered, so it goes into reversed A wave, S wave, D wave, and there is reversal of A wave. So this is A wave reversal, A wave reversal. That means the sign of fetal acidosis, imminent cardiac failure, or imminent fetal asphyxia. So there is chance of 20% chance of stillbirth, fetal asphyxia. So in case of abnormal DV Doppler, we will deliver by 26 to 30 weeks. We will admit the patient, we will do steroid cover, fetal monitoring, we will counsel the party, and we will deliver by 26 to 30 weeks after proper counseling. See the position of the ductus venosus. See, this is the umbilical vein. This is the abdomen of the baby. This is the head, abdomen, and this is the umbilical vein. Now this is the heart. So IVC will be here. The umbilical vein is connected. The umbilical vein that is connected to the heart by a ductus venosus. That is IVC. So this part is ductus venosus, very small part. So you have to put the probe accurately to get that flow. Once ductus venosus flow has been also hampered, or abnormal ductus venosus flow, we will check the umbilical venous flow. Umbilical vein flow, that is normal, it is uniform, there is no pulsation. So we will get a whoosh sound in umbilical vein pulsation. There is usually no pulsation in umbilical vein. If we will get pulsation in the umbilical vein, that means that is a sign of imminent fetal acidosis or fetal asphyxia. So if the pulsation sign is there in umbilical vein, so umbilical vein pulsation is the last sign we get. It's the last sign that we are getting, that is the sign of fetal acidosis. The fetus will either stillbirth or IVD labor. Next thing, so summarizing all the Dopplers, I will tell you. We will do initially in first trimester. I will do a uterine artery Doppler. We will put it in the chart, centile chart. In the centile chart, if it is in the 95th centile, it is more than 90th centile, it is 90th centile, then high risk of preeclampsia and FGR, and I will counsel her and will start aspirin, low dose aspirin 150 mg once daily till 34 weeks, so 36 weeks. In second and third trimester, I will do a umbilical artery Doppler initially. If the umbilical artery Doppler for more than 32 weeks, I will do MC Doppler. I have told that for less than 32 weeks, MC Doppler has a limited accuracy and it has no role to time delivery. So for less than 32 weeks, yes, I told you, for less than 32 weeks, you do umbilical artery Doppler, whether it is decreased end-diastolic flow or absent end-diastolic flow or reverse end-diastolic flow. Decreased end-diastolic flow, deliver by 34 to 37 weeks. For absent, deliver by between 32 to 34 weeks. For reversed, 30 to 32 weeks. Suppose the patient is 29 weeks, then I cannot terminate at this point with reverse end-diastolic flow. So I cannot do here MCA because it is 29 weeks. I will not do MCA. So MCA can't be done because the decision cannot be based on MC Doppler. So I will do here ductus venosus Doppler. So for this ductus venosus Doppler, there is absent or reversed A wave. I will deliver by 26 to 30 weeks after proper counseling. So this is the basic idea. And for umbilical artery, for more than 32 weeks, if umbilical artery Doppler is decreased end-diastolic flow, decreased end-diastolic flow, or it is more than 95th centile, the PI is more than 95th centile, then I will do a MCA Doppler. We will follow the patient with MCA Doppler, and for MCA Doppler, the PI is less than 5th centile. That means the CPR is less than 5th centile. So I will follow this patient, and follow up means daily or alternative Doppler will be done, and I will plan for termination accordingly by following the present. So for more than 32 week gestation, you do umbilical Doppler and you do MC Doppler. If the umbilical Doppler is more than 90 centile, so see for umbilical Doppler, if it is absent or reversed, so absent, that means you have to terminate by these weeks. If it is reversed, you have to terminate by these weeks. So I am talking about more than 32 weeks. So that means more than 32 weeks means absent Doppler means you have to terminate. Or for in decreased time flow, I have to terminate between 34 to 37 weeks. So when to terminate properly at 34 to 37 weeks? So I will decide by doing MCA Doppler. So if the MCA Doppler is normal, means there is no distribution of blood flow has been occurred. If MCA Doppler is less abnormal, that is PI is less than 5th centile, or CPR is less than 5th centile, or that is CPR is less than 1, that means I will do follow daily or alternative Doppler, and according to different other conditions like what is the live curve, what is the fetal heart rate, or any fetal heart rate abnormalities, accordingly I will plan for termination of the pregnancy between 34 to 37 weeks according to FIGO guideline. There are now RCOG new guideline, such we can monitor continuous CCTG, computerized TG monitoring. So in that case we see for short term variability, STV, we check for STV. So the value of STV we have to write in exam, the value of STV, by that which we can terminate the pregnancy. We will discuss in different section. Next is another concept in Doppler is MCA PSV. MCA, medial artery peak systolic velocity. If we will do a Doppler, we will get these findings here. There is a table will be there in which, see, this will find the PI is 2.34, RI is 0.88, SD ratio is 8.69. see the MCA PSV मतलब peak systolic velocity, that means middle artery peak systolic velocity. If what is the concept, this is done in mainly RH negative pregnancy, in RH negative pregnancy what happens, there is, if there is allo immunization, so there will be antibody formation, and that antibody will cause hemolysis. That maternal antibody will cause hemolysis in the fetus. Once there will be fetal hemolysis, so there will be fetal anemia. This anemia is a hyperdynamic circulation. Hyperdynamic circulation means in anemia hemoglobin normally decreases. So now the whole amount of blood, hemoglobin is less, but the rest is plasma. To increase the oxygen saturation or oxygen carrying capacity, the plasma, there will be more plasma and less hemoglobin. So this more amount of plasma, that is a condition called hyperdynamic circulation. So what will body do? Body will redistribute its own blood to maximum to brain. The same concept, to brain. That means there is increased blood flow to the brain. So increase blood flow to brain. So how we can check that? We can check that by doing MCA PSV, peak systolic velocity. So see, this is the peak systolic velocity, this is the end diastolic velocity, and this is the peak systolic velocity, and this is called timed average velocity. So we check the peak systolic velocity in MCA artery, MC Doppler. That is a sign of fetal anemia. If so, what happens in RH negative pregnancy? If the MCA PSV is more than 1.5 MOM, what is the concept of MOM? See, MOM is multiple of median. Actually, there is a median value. This median value, that is the median one, that is 50th centile value, that is median. If it is more than 1.5 of multiple of median, that means it is, if the MCA PSV is more than 1.5 of MOM, then that is a significant anemia or heart failure, chance of heart failure. So if it is more than 35 weeks, we will deliver the patient. If it is less than 35 weeks, we will plan for fetal hemoglobin or hematocrit, and we will do a chorecentesis, and we will plan for intrauterine blood transfusion. If the hemoglobin is more than 2 standard deviation below the mean, or hematocrit is less than 30%, then we will plan for intrauterine transfusion. So that is the concept of a 1.5 MOM. That means 1.5 times of the median value. Again, if it is less than 1.5 MOM, that means it is will repeat every 1 to 2 weeks. So how will you find that 1.5 MOM value? So there is a chart. So you do not have to remember the chart, just put the chart near your ultrasound machine. So you will compare the chart, or sometimes machine will give you the value, what is the centile value, or what is the median value, the machine will give automatically. So there is a software. So we'll put in the chart, and it will tell what is the median value and what is 1.5 MOM value. Then we will compare the value to the patient value. If it is less than 1.5 mm, we will repeat it every 1 to 2 weekly, and if it remains less than 1.5 mm, we will deliver by 37 to 38 plus 6 according to SCOG. And if it is more than 1.5 mm, for more than 35 weeks, we will deliver the patient, and for less than 35 weeks, we will plan for intrauterine transfusion according to fetal hemoglobin or hematocrit. There is another point that if the value is 1 to 1.29 MOM, 1 to 1.29 mm, that is mild anemia. For 1.29 to 1.5 mm, it is moderate anemia, and for 1.5 more than 1.5 mm, it is severe anemia. That means that's why for 1.5 mm we plan for termination. So how will you get that value? The value will be written in the chart. So what is 1.29 mm, what is 1.5 mm, the accurate value. See, the MCPSV here is 37.91 centimeter per second. So we'll put in the chart. So how much it is, whether it is less than 1 mm or 1.5 mm, the value will be automatically seen in the chart. So this is the concept behind MCA-PSP, that is done in RH negative pregnancy. The peak systolic velocity is very important that indicates the fetal anemia because of the hemolysis. So increased blood redistribution of blood into the brain, that leads to, we will find in the MCA-PSP. So this is all about Doppler in obstetrics. If you have any doubt, you can put in the comment box and put a query, so I can answer in all the queries in the next video. Thank you.